Hello, everyone. Thank you for joining the live event tonight. I am your host, Dr. Maria Sampoulos. I have the pleasure of having Dr. Dorothy Hitchmoth with us tonight. Hi, Dorothy. How are you?
I'm great. Great to be here. Excited to be here. Excited to have a chat.
Yeah, I'm excited to have you on today because I did a podcast about a week ago on telemedicine. We got a lot of feedback, and I figured I'd bring you on, one of the experts in the industry on this, and to get your insight on it as well. So, for those of you that do not know Dorothy, she is, very well known. I'm surprised you don't know her, but nationally recognized award-winning professor, lecturer, edgeless scientific papers and or editorials and book chapters, fellow of Academy and Retinal Society, and board certified. 22 years at the vets and served as chief optometry, director of residency, health analysis, and recognized telehealth professional expert. So I'll go on and on. I mean, nationally recognized American Optometric Association for the last 28 years, and has been named AOA Advocate in 2017. Young OD of the Year in 2003, received so many awards, and is well known and well respected in the industry. So welcome tonight.
Yeah, thank you. Thank you. What a blessing it's been to be in the practice for involved really 30 years, but in practice 26 years, and really advocating for patients. And, the bottom line, whatever it is that we're talking about or across the board, it's really about staying true to yourself and making sure that whatever you're about to embark on is really about taking care of patients, right? And so same holds true for the whole telehealth discussion, which is, I know, something you want to dive into tonight.
Well, yeah, I wanted a doctor's perspective, someone that's worked with AOA, because a lot of doctors have questions, and I want to touch on all those points, and I really want to get to those hard questions that doctors are asking. A lot of conversations going around it in different Facebook groups and in the industry as well. So let's just get started. What is telehealth and telemedicine?
So in general, what do doctors do? We overcomplicate everything. In a really tiny nutshell, telehealth is essentially the use of electronic information and telecommunication to communicate with the patient. And telemedicine is the practice of medicine using that methodology. Like that's Dorothy's abridged version. I don't think we should make it any more difficult than that. There are different groups that have come up with official definitions. The CDC, CMS, the American Telemedicine Association all have their abridgments. But honestly, it's communication far away. In fact, the Greek word root, tele, means far away. And, we've been telecommunicating with patients since the telephone. So in some ways, telehealth is not really new. It's just a new word, and we have some new methodologies for communicating with patients that are exciting and, scary, right? That's why we're all talking about this. When something is new, I think it's human nature to be a little afraid. And a lot of times appropriately afraid. I mean, as docs, I think we know some of the bad things that can happen if we don't do the right thing, or if patients don't access care in the right way. We've seen those things. So in the end, I think most people care. Most people are appropriately concerned. But on the other hand, there's all this amazing innovation that if we don't take advantage of, we're gonna make some mistakes, right? We're gonna be left behind. I mean, even our profession, quite frankly, could become, not really relevant if we don't forge ahead. To give you the long answer.
Yeah, I think that's what a lot of doctors, when they talk about telemedicine or telehealth, they don't focus on like what the possibilities could be or additions to the practice. They always focus on the negative. And I think that's what we get a lot of with new things in general in optometry. So how long have you been involved in telehealth? How have you seen it evolve over the last years that you've been doing it?
Yeah, really almost since my first days at the VA, which is a long time ago now, and I've since retired. But wink, wink, I've been in private practice the whole time and involved in industry for most of that time. So I've been really keeping pace with innovation from those early days. And I always feel obligated to give a little bit of a shout out to. So there's three dudes that I consider the fathers, because it was all dudes then. The fathers of teleretinal imaging. That was optometry's segue into telemedicine. And quite frankly, in my opinion, teleretinal imaging is where telehealth really started. We're talking about late 90s, early 2000s. There were two brothers, the brothers Cavallaro, and Anthony and Jerry, and they're Boston based. And if there are any NECO grads out there from the last 30 years, they know who I'm talking about. One brother was rolling out and was very, very involved in the Joslin Vision Network, which was teleretinal imaging. And the other brother was instrumental in bringing that concept of remotely imaging and asynchronously, quite frankly. Now we have a word for this. We did not call it that then. That was not even a thing, into the VA system. And, in the VA, because it's a closed, relatively uniform system, even though there are lots of different VAs and different things that apply to different VAs. The system is one system, and the mission is pretty clear: to take care of our nation's finest, take care of our nation's veterans, and make sure they have access to the best care in a timely fashion, and quite frankly, the latest innovation. So, fast forward, I don't know, over 20 years, that program evolved and evolved and evolved. There are now 1,000 retinal cameras deployed all around the country. Every single person that is trained in the VA has had some either direct or indirect exposure to what it means to have teleretinal imaging in the VA. And I will say, it's not the cameras, it's not the deployment of 1,000 cameras that gave the program success. And I think you can define success in a number of different ways. There were certainly some obstacles and pitfalls in the beginning, and I'll talk about, those. But, to quote one of the brothers Cavallaro, it's about the program. It's about the people. So, the camera doesn't matter, although, everyone is in this race to, create and innovate and make the most amazing tool, inexpensive, portable, high quality, high resolution, all this stuff, if you're talking about teleretinal imaging, because we've transcended beyond that now. But it's about the program. So, for example, in the VA, we didn't just deploy 1,000 cameras, we deployed people. And those people were trained in a very regimented way, with lots of quality control checks in place to educate the veterans that they were engaging with this amazing image of the back of their eye. A lot of veterans actually had regular eye care, some did not, but it was the program that mattered in the end. In fact, they did some data gathering in those early days and found that veterans that went through the teleretinal imaging program, despite possibly being seen in the optometry or ophthalmology clinics in the VA or in the private sector, had lower hemoglobin A1C. That's profound, right? Presumably, or the hypothesis was that it was because they were educated by these people who were running the program. So people didn't just take, the technicians didn't just take an image of the retina. They educated the patient about why they were taking the image, what they were seeing in the image, where those images would go, who would read them, who the doctors were that were responsible for making sure that there was something meaningful that happened with that picture of their body part, and talk to them about glucose control and what is a hemoglobin A1C and all these kinds of things. So in the end, despite, and I still believe this, and I strongly believe this, and I would say anybody out there that's looking to get into telemedicine, whether it's teleretinal imaging or full-on comprehensive eye care, which I think we're getting to the point where, those possibilities are becoming a potential reality. It's really about what's your program? How are you going to take care of that patient? How are you going to ensure patient safety? It's the same thing as anything else, right? Anytime you start something new, you hold to your principles and advocate for your patients and make sure that center stage, and good things will come, to include your ability to make a living. Like, I don't think it's appropriate to say, oh geez, how am I gonna make a living being a good doctor? That's okay, you can say that, right? You just can't leave your ethics behind. That's all. Simple.
Yeah, of course. So what are the big topics? I think a lot of doctors agree with teleretinal and things like that, and underserviced areas. But this new concept of comprehensive eye exam, a lot of that's going into corporate opticals. They're saying that they can't find coverage or coverage that they want on a weekend and things like that. What is the AOA's stance on that, and are there regulations they need to follow to have that in their exam lanes, or doctors to put it as in a second lane if they choose to?
Sure. So I'm gonna answer that in a couple of ways. I'm in rural practice, right? Have been for my pretty much my whole career, and so it is a challenge to recruit docs to come and help. I mean, I have a months long backlog. The two closest docs are booked out a year.
Wow.
Is it appropriate for us to have them waiting a year versus being triaged from, through some really amazing innovations? I think it would not be good for them to be waiting a year. Not only am I in a rural area, but I'm in an area that is surrounded by the poor rural. These are poor access, food deserts. I mean, you name it, right? Low health literacy. And, getting those folks triaged. I hate the word screening. Screening means that you've sort of been checked for a disease, or the implication is that you've been checked for a disease and off you go, you don't have it. Well, that's not true. I prefer the word triage. And if you're really going to triage a patient, again, it's not about integrating a simple tool. It's about making sure the patient is properly interviewed, a medical history is taken, that you don't cut corners on what you would provide live, and that you're not cutting corners on safe patient care. I mean, like the bottom line is it appropriate for me to put a -6 myope into the telehealth lane without a dilation, despite a perfectly maybe beautiful retinal image, remote controlled slit lamp, live videography, which, I mean, these are all things that are here, right? Amazing ultra wide field images, remote refraction, done. We're done. We got it, right? This is happening. It's great. I think all of us should be using these tools, as long as we're not skipping on what individual patients need. So, there's an old, term, cura personalis, which means treating the patient holistically, but really individually. So, no checking out and screening the -6s and 7s that really need a peripheral retinal exam. Same goes with not really doing a full medical history. I mean, I say this to people who are in their practices live, right? This is just a matter of good care. Are you asking people that are over 40, that had gestational diabetes, that have a mom or a dad with diabetes, who are overweight? Are you asking them about their risks? Are you educating them that they're high risk for diabetes, knowing with your public health mind, perspective as a doctor? I hope we all have a little bit of that about a third of the adult population in the United States is going to have prediabetes or diabetes. I think that's the figure now. So that's really what it's about. And it's an opportunity. This is why, I get excited about telehealth, because having a conversation versus no conversation, injecting some education versus no education, doing some triage versus no triage, I think is a win. But we just have to make sure that those that are the most critically at-risk patients are appropriately taken care of. And that's it. Everything else is great. I think to answer the other part of your question about the AOA is, I think that any of my, well, let me back up and say I've been involved in advocacy in the advocacy group and across many, many AOA committees for decades now.
And thank you for volunteering. Thank you for your time. That's super important because a lot of doctors don't give it out. And I've heard somewhere where only like 20% of the doctors do the work in the industry, but everyone else benefits. And people that work with AOA volunteer their time. It's super important. Again, thank you so much for that because you're paving the way for telemedicine and technology because a lot of doctors are looking for leadership for something like this. This is new.
Yeah, exactly.
What are you doing to tell these doctors what AOA is doing? So, because a lot of this stuff is not out there sometimes.
Yeah, I think I see a lot of chatter, and you and I were talking about this earlier. There's a lot of, the AOA hates telehealth. They don't support telemedicine. Well, nothing could be further than the truth, right? The AOA is not some thing. It's not some entity. It's not, a bunch of hired random people. It's comprised of docs like me. Most people involved in the AOA are in practice. They're in every modality of practice, from academia to commercial practice. So, I think the AOA represents very well the typical doctor of optometry. Its primary role is to advocate for patients. I mean, what an amazing and great thing. I mean, that's what's always attracted me is like, wow, this is an opportunity to take care of my patients outside the exam room. And once you realize the power of that advocacy, you're hooked. That's it. It's like anybody that has helped someone, it's the selfishness of altruism. It's great. And you realize that your voice sets off that ripple in the pond. And that, it's not just about taking care of those, however many patients you have in the clinic, but potentially protecting and helping thousands and even millions, because quite frankly, optometry is leading the world in a lot of ways when it comes to eye care. So I've been involved for years. I'm happy to have been involved for years. And because I'm involved, I kind of know what's going on. So one of the things that has been a regular conversation with formal committees and full sanctioning by the Board of Trustees. And I'm not going to speak for the Board of Trustees, but I will speak as an OD, and I will speak as a member, a longtime volunteer of the AOA hierarchy and leadership, that telehealth is something we're constantly talking about and constantly engaging all constituencies. So if you are out there in the airwaves, hello, and you have an opinion, talk to your state president. They have a direct line to the AOA. Go on the AOA website, contact the AOA directly. It's not that hard. Tell people what your opinion is. Put something in the chat. I don't know, what do we have, chats or whatever on this?
New chats, they comment on LinkedIn. We have actually a lot of comments. We have a lot of fans tonight for you. A lot of people saying hello and how much they love you and what you're doing.
Yeah. So,
that's great. But yeah, I mean, even I've sent in my Facebook group, just to email the executive director. He gave me his email, John Himes, and he said, just email me and let me know. He's very responsive, very proactive. Just email him and tell him what you're thinking, whatever the issue is, whether it's telemedicine or something else. Right. That's what the AOA is there for. If you're worried about something, people contact me and I said, hey, that's great, but that's an AOA question. That's an AOA concern. Yeah. I'm happy to present it for you. If you want to be anonymous as well, I'm happy to do that. So telemedicine is a big topic. It's changing. There's a lot of different moving parts right now with that, but also I think for your practice, a lot of doctors are utilizing it now with as easy services like contact lens follow-ups, myopia management follow-ups, things like that. Talk to parents. That has been something as well. as well. There's a lot of different platforms out there, so we'll see what ends up and what the AOA comes out with protocols so they stay up to par.
Yeah, and I think the audience should also know that there was a summit. So I'm going to tell you a COVID story now. So we had a summit in March of 2020 in St. Louis. Industry was invited, so anybody that had an innovation really was invited to participate in helping the AOA make some decisions about, how do we modernize our guidelines? Because we had some guidelines that were pretty outdated. Those guidelines were revised after that, and then COVID happened. So let me just tell you, I brought COVID to that meeting. Now, how ironic is that? I went from Seco to St. Louis, and I was coughing my bloody head off, never felt sick, looking at all the pollen floating around in the air in Atlanta, thinking it was my allergies. And 4 days after I returned from St. Louis, one of the lawyers gave me a little jingle and said, "Hey, we just started COVID testing here, and 4 of the people in the room with you have COVID." And I was horrified, of course, because this is pre-vaccine. People were dying in Europe. This was just horrible. I had just been in Europe doing some work for Zeiss. And I was like, oh my God, this is horrible. Please tell me that nobody's grandmother is, in the hospital, just terrible early pandemic fears. So rather ironic, but, fast forward, here we are. The AOA is literally in the middle of doing a revision because now we have had a pandemic between the first, which was the second revision, and now. So, now is the time to engage. Don't sit back and criticize. Get involved. The whole armchair quarterbacking doesn't sit too well with me, quite frankly, when it really comes to anything, whether it's scope of practice enhancement or taking care of your patients or forging ahead. Sometimes, bravely, I'm okay to take bullets. That's okay. I learn from people. If people sit back and they don't share, it's hard for me to grow too. And I want to hear from people. So yeah, contact me anytime. I don't want 30,000 emails, but every now and then there's somebody that provides that spark for me. And I'm so grateful for that. And all my mentors, before me.
So here's a tough question that always comes up when I, have a conversation about telemedicine. Is doctors think that telemedicine will replace them? Do you feel that it's going to substitute for patient care, or what are your thoughts? Or you think it's in addition to their practice?
I don't think it's not going to substitute for that care for now. I think it's going to take a long, long time. When I look ahead 30 years from now, and maybe somebody will look at this video, oh God, I hope not, in 30 years, we will all have tools in our homes, in our workplaces that allow for rapid triage, right? It may be looking at parts of our body that we don't look at and analyze to make certain diagnosis now. It may be, things you can't even imagine. There may be a station at your work. You go put this thing on your head, you stick your fingers in these things, and you get this full body scan, and you're appropriately triaged to the right expert. So right person, right time, right care. That's where I think we're going to have the most innovation, I should say, and stop wasting healthcare dollars, right? And we overutilize the system now. We know that. We're breaking the bank, and patients aren't necessarily getting healthier. One of my sort of claims to fame, I suppose, is my involvement with the VA Dartmouth Outcomes Group. So Dartmouth is very, very famous for developing a group called the Dartmouth Outcomes Group. And they literally look at data. They look at Medicare data, for example, and they realize that in places where people see the doctor the most, they get the most dead. Like, that's the most extreme example of their data analysis. But some more common things that some people may be familiar with is that they realized that there was no return on investment. Like, you're not improving the quality of life. You're not saving lives by doing certain tests. Just we were just doing them because you could do them, and it was like a screening, like screening people, for example, over the certain a certain age for prostate cancer, when there was a near 0% chance that they would die from that. It's not that you don't screen an individual, but there was no mass population screening reason to do that. But I digress a little bit. But I don't think we're going to be replaced. I think that we're facing in the next 40 years a healthcare provider shortage. I mean, there's like, every time I turn around, there's like 1,000 open positions just for optometry. And do I think we will be able to streamline over time and mitigate some of those shortages? Sure. Will we have better tools to reach the right patients who need us most? Absolutely. Artificial intelligence, neural networks will have more data. We'll know maybe when someone's 30 years old that they're at risk for macular degeneration, or that there's some indication that they're hyperinsulinemia and high risk for diabetes, and be able to funnel these people into the right programs and interventions early. At least that's my utopian, perspective on these things. But we're still going to need doctors. We're going to still need people who are empathetic, who care, and who have spent the time to acquire knowledge that even the best computer will not be able to synthesize, at least in the short term. So I'm not fearful. I think we'll be able to take care of more patients more efficiently. And this is an exciting, exciting time. This is almost as exciting as the telephone.
So, I remember like people saying like before, back in the day, like LASIK was going to end optometry. Contact lenses were going to end sell glasses. Right. And it just evolved in your practice. It's addition to your practice. They said the autorefractor was going to put them out of business. But it's a great way to see more patients. It's efficient now. We have retinal photography, visual. There's so much data we have now to be able to treat patients faster, better. I mean, there's a lot of solutions that we have, and makes you a better doctor, a better patient care. The other thing that I look about that I'm excited about, that's not a lot of information out there right now, is AI. And I think AI is a huge game changer, and I think it intertwines with telemedicine. And I think it's going to be a great way. I was reading an article in an ophthalmology magazine, and it's saying that they're coming out with AI for glaucoma. And I said, how great is that to have that for that patient where you're kind of questioning it, you don't know, maybe to have that additional tool, I think is important. I know there's a lot of AI out there right now for diabetes and things like that. If you have any insight on that, I would love to hear your thoughts on AI and telemedicine.
Yeah, AI, it's the same as when we first came out with normative databases, right? We're comparing a patient to a data set. But what's exciting now is we can compare patients to enormous data sets and their own individual data, right? So it's that individual change over time that's way more important than comparing a patient to the population, although that's important and may provide some clues. That will be refined, and we'll be able to drill that down. So it's very, very exciting. And it's not just glaucoma, diabetes, macular degeneration. I mean, you name it, like the race is on. Even just looking at the retinal vasculature for cardiovascular disease. And we talk about all these other things, but in the end, the number one killer of men and women globally is cardiovascular disease. Imagine being able to do some predictive care in that regard as well. But AI is where it's at. We're in that for the long haul. You're still going to need to access patients, and you're going to need to access patients that represent the people that need the most help, right? So it's really cool to say, oh, we have this great database, or we have this great AI tool, and here are all the people in it. Well, still, all the people in it might be the same darn people that would already get the care anyway, and maybe a lower risk population, and we may not be reaching. So the key, to me, the holy grail, is reaching through medium like this, talking to people who might have a cell phone but don't go to the doctor, right? who don't have a car but might be able to communicate, who don't have, haven't been informed for one reason or another, right? Who don't have the ability to or the means to access healthcare in a way that may be helpful to them. And the list is really long. If you're trying to find out where your next meal is coming from, or you live in a place that's not safe, healthcare is last on your mind. It is last on your mind, and that's coming from someone who grew up in poor neighborhoods. So those are the people that I like to spend my time advocating for, and the rest of us figure this stuff out.
Sure. And so, what can telemedicine help doctors improve with healthcare and quality of life?
So what I'm excited about is testing what do patients do when they get information, right? One of the things that we do a lot in medicine, and that includes optometry and healthcare in general, if you will, is patting ourselves on the back for this really cool information that we can pull together and these diagnoses that we can make and deliver. But, really it's about, for example, I like to talk about diabetes, right? I'm high risk for diabetes. My mom's had diabetes since the age of 38. My brother's had diabetes since the age of 45. I'm in my 50s. These are two primary relatives. And so, it's always like right there. What motivates me to, put that piece of chocolate down that I probably don't need, or get out and take a walk? That's the crux of changing someone's quality of life as they age, right? What are the tools that are being developed that work to change behavior? That's it. Because when you change behavior, you change health, at least for chronic diseases, right? At least for chronic diseases. And so diabetes, heart disease, all those kinds of things. So, there are some really, I was just looking at one today, and I don't know if we're into like mentioning specific tools on your show, but there are, one that caught my eye that I saw on TV that I'm not affiliated with and won't get in trouble for mentioning, I think, is like that Noom. Everybody's seen, well, if you watch TV when you're an old lady like me, because I hear young people don't look at TV anymore, there's something called Noom. They have some great data that shows that this behavioral modification tool actually helps patients exercise and lose weight and lower their hemoglobin A1C. I mean, that's a win. That's what this is all about, right? So all the fancy tools to make the diagnoses, that's really secondary to what we're trying to achieve in public health.
Well, thank you so much for joining us tonight. I think everyone's going to get some great information from this. Telehealth is a hot topic. I think we'll have more conversations on this. I'll have you on again as being one of the experts in the industry. And I know you do a lot of work with different companies as well. So I think your insight is valuable. We got a lot of comments, a lot of fans for you here tonight. And I see you probably have more comments as people watch this video after the fact. So I want to thank you so much for joining. If someone wants to contact you, can you provide your email?
Yeah, sure. It's Dr. Dorothy at hitchmotheyecare.com. You can also message me on LinkedIn.
All right. Thank you everyone for joining us tonight. And thank you, Dorothy, for joining as well.
Thanks. It was great to be here. Thank you.
Bye.